will be of extreme importance, not only for the physiology, but also for the clinical life as well. So for the clinical exam and for, let me just close the communications. So back to what I'm saying, that the people, to understand the physiology of the people, is will reflect not only your academic life and the basic exams, but also the clinical life as well. So it is crucial to know and to understand what is the abnormalities, or what are the abnormalities of the people, and how to address them. So today's lecture has a great deal of clinical component, and this is mandatory to understand the problems of the people. So today's lecture, the outline of today's lecture will be about the functions of the people. As we get used to this now, we start by the functions of each structure, and we get a hint about the anatomy of each structure. So we will talk about the anatomy of the people and the muscles control the size of the people. And then we will go to the pupillary reflexes, either the light reflex or the near reflex or the accommodation. And then we will address the abnormalities of the pupil, such as afferent pupillary defect and efferent pupillary defect. So start by the anatomy of the pupil. So the anatomy of the pupil has the pupil is an aperture present in the center of the iris. This aperture is controlled by two muscles. Our two muscles will have an effect on the size of the pupil, either by constriction or by dilatation. So the first one will be the constrictor pupil muscle, which is a circular muscle acts as a sphincter around the pupil. And the second one will be the dilator pupil muscle, which will, by its constriction, it will cause dilatation of the pupil. So what is the optimum size of the pupil? Well, let's first know what the undilated pupil and the dilated pupil, both of them will be under certain light and dim conditions, meaning that the light will undergo, or the pupil will undergo constriction under the effect of light, but it will undergo dilatation under the effect of darkness or dimming of the light. So this is the main muscles control the pupil. The size of the pupil will be variable. It will be around 2.5 and 4 millimeters. So let me ask you, optically speaking, as I told you, as I explained this earlier, how can the size of the pupil affect the visual acuity or affect the vision by either narrowing or dilatation? So if it is narrower than 2.5 millimeters, what will happen? And if it is more than 4 millimeters, what will happen? Can you tell me in the chat box? Yes, exactly. So if it is smaller, it will decrease the visual acuity by diffraction. And what happens if it is larger? It is not only chromatic aberrations, but also the spherical as well. So it will be affected by the chromatic and spherical aberrations. So remember this when we will talk about the visual acuity lecture in the next lecture. So myotic pupils can be considered myotic if it is less than 2 millimeters, and it can be considered large or mydriatic if it is larger than 7 millimeters. The size itself will depend on many variables. First of all, the age. The age tended to be smaller in infants due to stronger constrictor pupillary muscle, and tended to be smaller in elderly in a phenomenon called senile meiosis. Also, it will tend to be smaller during sleep due to parasympathetic tone. So the parasympathetic will cause constriction of the sphincter pupillary muscle. The refraction also will have a rule on, or have an effect on, the size of the pupil, as hyperopes will have smaller pupils. So since hyperopes have small everything, small cornea, small axial length, so they will have small pupil as well. The color also, sometimes they can give an impression that the iris or the pupil is larger, such as in case of dark iris, they tend to show small iris, but or small pupils. But if the color is light, like blue iris or green iris, then the pupil or the pupil size tend to be larger. So here we come to a term called chorea. So chorea in Latin meaning pupil, and iso means equal. So isochorea meaning that the pupils in both eyes are equal in size. So normally two pupils are equal in size. This is called isochorea. And the difference, it is called anisochorea. So anisochorea meaning that there is a difference in the pupil size between both eyes. Usually this difference is by 0.3 millimeters or more. Sometimes, if it is there is what's called the physiological anisocoria. In the physiological anisocoria, the difference between both eyes is less than 0.3 millimeters. So can sometimes be about 0.1 millimeter, and it is present in about 20% of normal individuals, so it is not uncommon. And it is still called anisocoria, but it is physiological anisocoria. It doesn't reflect any diseases. So here is what is meant by anisocoria. You can see that the right eye has a larger pupil and the left eye has a smaller pupil. So which one of them is the abnormal pupil? Which one of them is the dilated pupil is the abnormal and this is the normal one? Or this is the pupil which is constricted or meiosed abnormal and this is the normal one? This is what we talk about at the end of the lecture. So now let's talk about the functions of the pupil. What are the functions of the pupil and the iris itself? So the iris pupil diaphragm has different functions. First of all, it will govern the color of the eye according to the amount of melanin pigments present in it. Also, it will control the amount of light enter the eye. So by meiosis, we limit the amount of light which will happen in the daylight. But during night, then the pupil will dilate, allowing more light to enter through the eye. Also, as you mentioned, it has a rule to prevent the chromatic and spherical aberrations. So the periphery of the iris will cut the peripheral rays and prevent them from entering the eye, leading to decrease the effect of spherical and chromatic aberrations. Also, it increases the depth of focus. So as you can see here, when the pupil is dilated, there will be more light rays entering through the periphery of the lens, causing that the focus will be at distant point. So any object present in front of it or behind of it will be out of focus. As you can see here, this is the near object is in focus and the far object is out of focus. But if we narrow the pupil, the light rays will pass through the axial rays, or the axial rays will pass through the center of the pupil and center of lens, causing extension or extending the depth of focus. So both targets, the near and far, will be in focus. So the pupil can, by constriction of the pupil, this will increase the depth of focus. Also, it has a role in aqueous drainage, as the aqueous will pass from the posterior chamber to the anterior chamber, as we said yesterday, and this passage will be through the pupil normally. Let's talk about more details about the anatomy of the iris muscles. So we have two muscles. We have the constrictor pupillae or the sphincter pupillae muscle and the dilator pupillae muscle. If we have a frontal view, we will find that the constrictor pupillae muscle is present at around the opening of the pupil in a concentric manner. And as you can see here, this is a side view, this is a cut section. So here is the pupil, or here is the pupil, and here is the iris, while the dilator pupil muscle is present more toward the ciliary margin, as you can see here. The sphincter pupillae muscle is a muscle act as a narrow circular band around the edge of the pupil. So it's by its constriction or by its action, this will lead to constriction of the sphincter, as it will act as a sphincter, so it will cause narrowing of the pupil. This is the constrictor pupil muscle is supplied by the parasympathetic system, as we know, which comes from the oculomotor nerve. So the parasympathetic will pass with the oculomotor nerve, will relay in the ciliary ganglion, then the postganglionic parasympathetic fibers will supply the constrictor pupillae muscle or the sphincter pupillae muscle. As you can see here, the center will be coming from the Edinger-Westphal nucleus that will give the preganglionic fibers passing until it reaches with the third nerve until they reach the nerve to inferior oblique, then they will relay at the ciliary ganglion, then the postganglionic fibers will pass with the short ciliary nerves until it supply the sphincter pupillae muscle and the ciliary muscle as well. So by stimulating or by supplying the sphincter pupillae muscle, this will lead to meiosis, and by supplying the ciliary muscle, this will lead to accommodation. Here is the same pathway as well. The Edinger-Westphal nucleus will give the preganglionic nerves pass with the third nerve with the nerve to inferior oblique until it will reach the ciliary ganglion. And then from the ciliary ganglion, it will give the postganglionic fiber that will pass with the short ciliary nerves until it supplies the constrictor pupillae muscle. So this will be the apart from the light reflex that we will talk about later. The dilator pupillae is a muscle that is present from the edge of the constrictor muscle until the ciliary margin. So this muscle has a radial pattern. So here is its location, and it has a radial pattern. So once it is contracted, this will lead to pulling of the edge of the pupil toward the ciliary margin, causing dilatation of the pupil. And this muscle is under the effect or under the supply of the sympathetic system. So once the sympathetic is stimulated, this will cause dilatation of the pupil. And what is the pathway of the sympathetic? What will we know now? The sympathetic starts first by, or the center for the sympathetic starts by the hypothalamus that will give fibers that will pass into the neck and the chest, and then it will relay on the ciliospinal center of Budge from C8 to T2. Then from C8 to T2, the fibers will pass, or preganglionic fibers will pass above the apex of the lung and with the common carotid artery, and then it will relay in the superior cervical ganglion, which will be the third order neuron. Then from the superior cervical ganglion, the postganglionic fibers will pass. Some fibers will pass with the branch of the external carotid artery, which will supply the pupil, which is called the pseudomotor fibers, which will supply the sweat glands of the face. And the main fibers will go with the internal carotid artery to pass along the branches of the internal carotid artery, then to leave the internal carotid artery to pass with the branches of the ophthalmic nerve, which is the nasociliary nerve, then the long ciliary nerve, then will supply the dilator pupillae muscle. So this is the supply of the dilator pupillae muscle. It comes from the sympathetic system. So let me test you. If I have a problem that affects the parasympathetic system, this will lead to dilatation or constriction. Exactly. So if I have a problem with the parasympathetic system, this will lead to dilatation of the pupil, and the vice versa. So if there is a problem with the sympathetic, this will be causing a constricted pupil. So here again, the pathway in more illustrated form. So the first order neuron will be the hypothalamus. From it, central fibers will pass until they descend down through the neck until the lateral horn cells of the gray matter from T2 to C8, or what's called the ciliospinal center of Budge. that will give the preganglionic fibers will pass as a second as a preganglionic fibers to relay in the superior cervical ganglion or the second order neuron. Then the postganglionic fibers will pass through the second order neuron that will pass as a third order neuron with the common carotid, then with the internal carotid, then will pass through the branches of the ophthalmic nerve. So it will pass with the ophthalmic nerve, then it will pass with the nasociliary nerve and long ciliary nerves to supply the dilator pupillae muscle. Again, in a comparison, the parasympathetic, I'm repeating it again and again because this is very important and a very crucial basic information that you need to remember it by heart. So the center in the parasympathetic will be the midbrain in the pretectal nucleus that will give supply to the Ellinger-Westphal nucleus in both sides. That will the parasympathetic fibers will pass with the oculomotor nerve, then nerve to inferior oblique, so that these preganglionic fibers will relay in the ciliary ganglion, and the postganglionic fibers will pass with the short ciliary nerves to supply the constrictor pupillae muscle. Just hold on to charge the laptop. Then the sympathetic fibers will start from the hypothalamus, or this is the center, or the first order neuron. Then the first order neuron fibers will pass through the neck to relay on the cerebrospinal center of Budge from C8 to T2. Then the second order neuron fibers will pass through the neck to, or with the common carotid artery, until they relay on the superior cervical ganglion, which act as the second order neuron, or the superior cervical ganglion. From it, third order neurons will arise until they will pass with the branches of the trigeminal nerve or the ophthalmic nerve, then the nasociliary nerve, then the long ciliary nerve, then finally will reach the dilator pupillae muscle. The same again, illustration for sympathetic and parasympathetic. Okay. So this was just a rapid introduction to know what is going on and what are the pupillary light reflexes and how can we understand them. So the first one, or the first reflex, is called the light reflex. The light reflex happens when we shine the light at one eye. Then the light reflex means that the both eyes will constrict. So if we shine light into one eye, only one eye, this will lead to constriction of this eye and the constriction of the other eye. The constriction of the ipsilateral eye is called the direct light reflex, while the constriction of the other eye, it is called the consensual light reflex. So in case if the patient is normal, or in normal individuals, the constriction of both pupils will be by the same site and the same time and the same extent, as long as this is a normal individual. So in this condition, this is called a normal light reflex. So again, the light reflex means that when we shine the light into one eye, this will lead to constriction of both eyes. So the constriction of the same eye will call the direct light reflex, and the constriction of the other eye is called the indirect light reflex. Here we see that when we shine the light at one eye, there is a constriction of the same eye and on the other eye as well. So why do this happen? This is because of that when the light will pass through its pathway, it will reach finally the pretectal nucleus. and then the pretectal nucleus will supply the Edinger-Westphal nucleus on both sides. So the Edinger-Westphal nucleus will be the center for third nerve and the center for parasympathetic supply to the constrictor pupillae muscle. Since they are supplied on both sides, once the right or the left eye is stimulated, this will lead to constriction of both eyes. So let's see an example.
The looking over two again. Just keep looking
So
over there.
by shining the light at one eye,
Close to the
there is
central.
constriction here and there.
Over here to the direct, into the central, both coming down equally. And now we're going to do the swinging flashlight test. We're going to go from one eye to the.
So again, by doing the flashlight, the flashing one eye, this will lead to constriction of this eye and the constriction of the other eye on the same time. Then the examiner is doing another test that we will come to later on. It's called the swinging flashlight reflex. So what is the pathway? Here, this is one of the most important information that you need to know either in this lecture or in the basic course and the basic for the basic exam and for life, which is the light reflex pathway. So let's start. Okay, so what is the receptor here? When the light is shown into the eye, they will be received by the ganglion cells. The ganglion cells have nerve fibers, as we know, so these nerve fibers will collect to gather in the optic nerve, so they will make the optic nerve. So light impulse will pass through the optic nerve, and here we come to the chiasma. The chiasma, as we know, there is a decussation, so that the temporal the temporal fibers will continue on the same side, while the nasal fiber will decussate to the opposite side. Again, the nasal fiber will decussate on the chiasma, while the temporal fiber to continue without decussation. So we know all this. So what happens next? Then the light reflex will pass through the optic tract. Then it will supply the pretectal nucleus. Here we can see that there is then we come to the pretectal nucleus, and the pretectal nucleus will supply the Edinger-Westphal nucleus on both sides. So the pretectal nucleus will supply the Edinger-Westphal on both sides. Here is the crucial thing here, that the light reflex didn't pass through the lateral geniculate body. So the optic nerve fibers carries two types of fibers. Fibers which contain visual sensation, these fibers will relay in the lateral geniculate body. Fibers which carry the pupillary response, then this will relay on the pretectal nucleus, and that's why the light reflex is considered a subcortical reflex. So it doesn't reach the cerebral cortex, but it was subcortical, as its center is present in the brainstem. So from Edinger-Westphal nucleus on both sides, what will happen? The fibers or the preganglionic fibers will pass through the third nerve, or the inferior division of the third nerve, within the inferior division of third nerve, within the nerve to inferior oblique. Then it will relay in the ciliary ganglion as a preganglionic fibers. Then the postganglionic fibers will pass with the short ciliary nerves until they will supply the constrictor pupillae muscle or the sphincter pupillae muscle. So again, when stimulating one eye, this will lead to a passage of the impulses that is carried on the pupillary fiber through the optic nerve, then the optic chiasma, then the optic tract. But through the optic tract, it doesn't reach the lateral geniculate body, but it will leave the optic fiber or leave the optic tract to descend down to the pretectal nucleus. The pretectal nucleus will supply the Edinger-Westphal nucleus on both sides, as you can see. From each Edinger-Westphal nucleus, third nerve will carry the efferent fibers until it relay in the ciliary ganglion, so that it will relay through the short or supply through the short ciliary nerves to the constrictor pupillae muscle. So one fibers or one optic nerve supply will cause, or one eye stimulation will cause response in both eyes due to stimulation of the Edinger-Westphal nucleus on both sides. The same pathway here, you can see that stimulation of the left eye will pass through the left optic nerve and chiasma and the tract, and then it will, the optic tract fibers will continue to the lateral geniculate body, but it will leave the tract to supply the left pretectal nucleus. From the left pretectal nucleus, it will supply the left and right Edinger-Westphal nucleus, so that they will continue through the third nerve to supply both eyes, causing meiosis of both eyes. So there are two types of fibers within this light reflex. Those in red is called the afferent pathway. So the afferent pathway starts from the eye until they reach the pretectal nucleus. And those in green, this is called the efferent pathway. So the light reflex, meaning that stimulation of one eye will cause the impulses to pass through the afferent pathway, then the response will be got by two eyes through the stimulation of the two efferent pathways of both eyes. I hope that this concept is very clear to you. Now we come to another reflex. It's called the near reflex. So the near reflex, it is considered by some, it is a synkinesis, meaning that it is not like a true reflex. It is just a connection between different responses together. So when looking to a near target, there will be a certain action or connection between three events. One of them is the accommodation. The second is convergence, and finally meiosis. So when looking to a near target, or when when we are looking to a distance, then suddenly looking to a near target, this will lead to stimulation of this sequence of actions, which actually this is not a sequence; they are occur simultaneously. Sometimes the light and the near reflexes or centers are closely related together in the brainstem. There are some conditions that will cause lost light reflex, but the near reflex is present. But the reverse is not true. As we know, there is no clinical condition in which the light reflex is present, but the near response is absent. So if you find that the light reflex is present, then the near response, they will be present. But if the light reflex is lost, well, the near reflex can also be present. Again, the light reflex and the near reflex are closely related to each other. So there are some diseases that may cause loss of one of them or loss of two of them. So they are both can be present, or they are both can be lost, or one can be present and the other can be lost. But in this condition, it is always the light to be lost, while the near reflex will be present, but the reverse can never occur. Although the final pathway for the near and light reflex are identical, like the third nerve and ciliary ganglion, but the center for the near reflex is ill-defined. So we know the center for the light reflex, like the pretectal nucleus, but we don't know, or we don't know exactly what is the center of near reflex, but we just know its location. So here is the near reflex. When we are approximating a near target, there will be constriction of both pupils under the effect of the sphincter pupillae muscle, and there will be convergence, so both eyes looks inside, and there will be accommodation, so the accommodation will increase the power of the lens in order to see this near target. The near reflex is probably under the effect of the frontal and the occipital lobe or the supranuclear control of the frontal and the occipital lobe. And the midbrain itself has the center for the near reflex that is located more ventrally than the pretectal nucleus. And that's why whether it's a pinealomas will involve the dorsal interneuronal neurons cause light reflex to be spared or the cause will cause lost or involving the light reflex and sparing the near reflex. So it's give you like an example to understand this. So consider that this is the brain, so this is the frontal lobe, and this is the occipital lobe, and this is the brain stem. So you can find here is the midbrain. In the midbrain, there is two centers. The near reflex will be more anterior or more ventral, while the light reflex, which is the pretectal nucleus, will be more dorsal. That's why if there is a lesion involving the aqueduct of Sylvius or involving the dorsal surface of the midbrain like pinealomas, this will cause involvement of the light center first. So this will lead to affection of the light center or affection of the pretectal nucleus, leading to lost light reflex, while the near reflex will be intact. So NN, near intact. And this is what occurs in what's called dorsal midbrain syndrome or Parinot syndrome. This is like an advanced clinical information, but who knows, you may be asked about it in the basic or even the clinical exam. By the way, this sparing of the near reflex, this is called light near dissociation, and we will talk about in a few minutes or through this course. So what is the pathway for the conversion reflex? What happens in order for the eye to converge? The stimulus will be the blurred retinal image, so fibers will pass through the same pathway like the optic nerve, then the optic chiasma, then the optic tract, but here the stimulus is vision. So the fibers will pass through the lateral geniculate body. So here is the difference, that the fibers for the convergence reflex will pass through the lateral geniculate body, and from it will pass through the optic radiation until it will be perceived by the visual cortex, either the striate cortex area 17 or the extrastriate cortex area 18 and 19. So this will be the center. Then it will give fibers that will supply the pretectal nucleus. Then from pretectal nucleus, the pretectal nucleus has the oculomotor medial rectus nucleus, or the oculomotor medial rectus nucleus is present in the superior colliculus of the midbrain at the pretectal area, as we said in the neuroanatomy. So both medial recti will be supplied, leading to stimulation of the medial rectus on both sides, causing convergence. So here the pretectal nucleus will supply the Edinger-Westphal nucleus on both sides, causing the stimulus or causing stimulation of the medial recti passing through the oculomotor nerves on both sides that will stimulate the right medial rectus and left medial rectus, causing convergence. So this is the pathway of the convergence reflex. The second reflex will be just more or less similar to the convergence reflex, which is the accommodation reflex. Again, the accommodation reflex is stimulated by blurred retinal image. So the impulses will pass through the optic nerve, optic chiasma, optic tract, lateral genicular body again, optic radiation, and striate cortex, and extrastriate cortex. Then from this will go to the superior colliculus in the midbrain, which contain the Edinger-Westphal nucleus again and again. So it will supply the oculomotor nerve. Then the oculomotor nerve will supply give the preganglionic fibers passing to the ciliary ganglion on both sides, supplying the ciliary muscle, causing contraction and leading to accommodation. So this is the difference between the accommodation reflex and the convergence reflex. It is just what is the end organ. It is the ciliary muscle or it is the medial rectus. So both of them will be supplied by the branches from the oculomotor nerve. So to summarize, here is the pupillary light reflex will pass through the optic nerve, optic chiasm, optic tract. Then it will leave the optic tract to the pretectal area. It will supply the pretectal nucleus that will supply the Edinger-Westphal nucleus on both sides that will give the efferent fibers that will pass through the oculomotor nerves to both eyes, and it will relay in the ciliary ganglion, and it will supply the constrictor pupillae muscle. Then we have the convergence reflex in which the fibers will pass through the optic nerve, optic chiasm, optic tract. And then the difference that it will go to the lateral genicular body, then the striate and the extrastriate cortex within the visual cortex that will supply the pretectal area again, or pretectal nucleus that will supply the Edinger-Westphal nucleus on both sides. So this will be the same like in the convergence and accommodations. Both of them will be, the fibers will pass through the oculomotor nerve to supply either the ciliary muscle or the lens, the ciliary muscle too for accommodation, and the medial rectus for convergence. So remember that this is the difference, lateral genicular body and visual cortex. That's why the accommodation reflex and the convergence reflex, it is like a cortical reflex, because the cerebral cortex is involved. So by knowing the normal reflex, we need to know what are the abnormalities of the pupillary light reflex. First of all, we could have, or the patient can have, a problem with the afferent pathway. So in this case, it is called afferent pupillary defect, or APD. Afferent pupillary defect can be either it is due to involvement of the afferent pathway. So the afferent pathway that receives the visual impulse is broken or damaged. And this can be either total or subtotal. So in case of total, it's called the total afferent pupillary defect. And if it is subtotal or less than total, then compared to the other eye, it's called the relative afferent pupillary defect. So let's start by the total. The total afferent pupillary defect has its another name. It's called the amerotic pupil. So what does it mean by having an amerotic pupil or total afferent pupillary defect? This means that the visual pathway is completely damaged or complete cut, or there is a severe destructive retinal lesion that will cause total blindness in this affected eye. So if there is like complete cutting of the optic nerve, or the severe destructive lesion of the retina, then this will cause total blindness, and the pupil here is called amerotic pupil. So what are the characters? And here please concentrate with me. The involved eye is completely blind, meaning that it can see no light. It's called no light perception. And if we stimulate the involved eye, so the direct reflex will be absent. And also there will be absent consensual light reflex on the normal side. And I will show you now in the figure. But when the normal eye is stimulated, both pupils react normally. Again, when stimulating the diseased pupil or the diseased eye, there is no response, or either on the same side or the other side, because the afferent is completely lost. But if we are stimulating the normal eye, there will be response on both sides equally. If there is diffuse illumination, both pupils are equal in size, so this, our afferent defect, does not cause anisocoria. Again, please bear in mind that afferent pupillary defect does not cause anisocoria, while the near reflex is normal in both eyes. Let's see what does it look like. So let's suppose that there is a complete cutting of the optic nerve, and you are stimulating the right eye with the with this light. So the light impulses will not pass through the optic nerve, so that neither the right Edinger-Westphal nucleus will be stimulated, nor the left Edinger-Westphal nucleus will be stimulated. So the constrictor pupillae muscle on the same side will not be stimulated, and the constrictor pupillae on the other side also will not be stimulated. So that this will lead to absence of the direct light reflex on the right eye and the absence of the consensual light reflex on the left eye. But what happens if we stimulate the normal eye? If we stimulate the normal eye, then the light impulses will pass into the left optic nerve, then the optic chiasma, and then the optic tract, and then it will leave the optic tract to supply the left pretectal nucleus, which will supply the right Edinger-Westphal and left Edinger-Westphal, and both of them will pass through the oculomotor nerve on both sides to supply the constrictor pupillae muscle on the right side and the left side. So this will lead to constriction of the normal eye and the abnormal eye. So by stimulation of the normal eye, this will cause constriction of both pupils normally and equally, because the pathway is intact, because the afferent pathway of the left eye is intact, and the efferent pathway of the right eye and left eye are intact. So I hope that you get this. So in total afferent pupillary defect, by stimulation of the normal eye, both eyes will constrict normally. So there will be normal direct and normal consensual. But by stimulating the blind eye, there will be absence of reflex in both eyes. So there will be absence of the direct and absence of the consensual. This is called the total afferent pupillary defect. If the lesion is not completely destructive to the retina or the optic nerve, then so just to say that something, that the afferent pathway consists of 5 stations. So it will start from the retina, then the optic nerve, then the chiasma, then the optic tract, and finally the pretectal nucleus. So any lesion involving any one of these 5 areas can cause afferent pupillary defect, which could be total or relative. What makes the relative afferent pupillary defect distinguished or unique? That it has a paradoxical response to light. Before, just to explain the other name of the relative afferent pupillary defect, it is called the Marcus-Gunn pupil. So what makes the Marcus-Gunn pupil unique? That it has a paradoxical response to light. So if the patient has a relative afferent pupillary defect, which is one of the most important and one of the most localizing signs in ophthalmology, or if the patient has RAPD, or relative afferent pupillary defect, so this means that the patient has a lesion involving the visual pathway. This visual pathway can be either starting from the retina, can have a severe retinal disease, or incomplete optic nerve lesion such as inflammation or compression, or a chiasmal lesion, or an optic tract lesion, or a pretectal nucleus lesion. So if there is a lesion that is not complete or a severe in relation to the other eye, which is normal, then this eye will show relative afferent pupillary defect. And how can we test for, or how can we identify that this patient has relative afferent pupillary defect? This can be done by the swinging flashlight test. So what is the swinging flashlight test? So this test is simply, you just shine the light at one eye or the normal eye, so both pupils will constrict. And in this condition, this is because of normal direct light reflex, and there will be normal indirect light reflex. But when we are swinging to the other eye, which is the abnormal eye will undergo dilatation instead of constriction. And this occurs because the abnormal eye now is under two forces, or under two responses. The first one will be the constriction of the abnormal eye, and the second one will be the dilatation caused by withdrawal from the normal eye. And this is what's called the paradoxical response. Let's illustrate this or let's see this animation can show when we are shining the light into the right eye, it will constrict. But when we are withdrawing the light from the right eye into the left eye will dilate instead of constriction. So let's see in this also the diagram will make you understand it better. If there is no light, both pupils will be mid-dilated. When we stimulate the left eye with the light, this will cause constriction of the left eye by the direct light reflex, and there's also constriction of the right eye by the consensual light reflex. So there is normal response to light. So what happens when we withdraw the light from the left eye to the right eye? When we swing the flashlight from the left eye to the right eye, the left eye starts to dilate because we withdraw the light from the left eye. So consequently, the left eye will, or the right eye will dilate as well by the indirect reflex. So the indirect reflex or the direct reflex, it is not only by constriction, it is also for dilatation. So if we shine the light at one eye, both eyes will constrict. If we remove the light from one eye, both eyes will dilate. So both eyes will be under the same, or will be affected by the same action. So what happens when we withdraw the light from the left eye to the right eye, and now we are shining the light in the right eye? In the normal condition, then the right eye will constrict by the direct light reflex, and the left eye also will constrict by the indirect light reflex. So this will be normally. But in case if the patient has relative afferent pupillary defect, say for example that he has an optic nerve disease, then this right eye will be under two effects. The first one will be the constriction, which is caused by the light on the right eye. And this effect is weak. And the other effect will be dilatation, which is caused by withdrawing of the light from the left eye. And this will be strong because the left eye has stronger optic nerve functions and stronger retina than the right eye. That's why the strong will conquer the weak, leading to dilatation of the right eye instead of constriction. So let's see this example of a relative afferent pupillary defect to understand what I mean. So what happened here? When we are stimulating the left eye, it constricts. But once we are removing the light from the left eye and shine the right eye, the left eye will dilate, so that the right eye will dilate consequently instead of constriction, because the optic nerve here, or the afferent pathway in the right eye, is weak. So it cannot overcome the dilatation effect caused by withdrawing the light from the left eye. So did you get the difference? Does anyone has a problem with this? Okay, so I guess that everyone is understanding. This is very good. How can we grade the relative afferent pupillary defect? This can be different methods, but there is a common clinical scale in order to grade the relative afferent pupillary defect, or there is a test that we can do to grade the relative afferent pupillary defect. So let me illustrate it in numbers. Let's say, for example, that this is the left eye, and this is the left optic nerve, and this is the right eye, or this is the left and this is the right. Doesn't make any difference. Let's say, for example, that this eye has an afferent pathway strength of 100%, and the other eye is 90%. So let's say that there is a very minimal inflammation, or there is a very minimal retinal lesion that will affect the visual fibers or affect the optic nerve fibers. So the left eye is slightly stronger than the right eye. So when we do the swinging flashlight reflex, there will be not a complete response, but there will be a mild response. This mild response is called grade 1. In grade 1, we have a weak initial pupillary constriction followed by greater redilatation. So since that there is a huge number of normal optic nerve fibers in this condition, so there will be some initial constriction. But eventually, the dilatation effect of the left eye will overcome the constriction effect of the right eye, so this will lead to redilatation and relative afferent pupillary defect. Let's say, for example, that it is about 60%. So 60% of weakness or damage of the afferent pathway fibers, this will lead to grade 2 relative afferent pupillary defect. So initially the pupil will stall. Stall meaning that it will stand still, it will be fixed. So when we shine the light into the left eye, both pupils will constrict. When we swing the flashlight from the left eye to the right eye will not show constriction, neither show dilatation, but it will be fixed initially. So initially it will be because there is some balance between the normal or the diseased and the normal afferent pathway fibers. So there will be initial stall, and then eventually the left eye dilatation effect will overcome the constriction effect of the right eye. So this will lead to dilatation at the end. In the grade 3, let's say there is a severe damage. Let's say, for example, that there is only 20% of the optic nerve fibers are working in the right eye. So once we are moving the light from the left eye to the right eye, this will lead to initial dilatation, immediate dilatation. So there is no power of the optic nerve fibers here. It's all weak, so the optic nerve fibers cannot constrict the pupil. Doesn't have any strength to constrict the pupil. So this will be leading to dilatation immediately. Let's say, for example, that this is a 0% or there is a complete damage of the optic nerve fibers, then this is called grade 4. And the grade 4, there is no reaction to light at all, and this is called the amarotic pupil that we just mentioned. So this patient doesn't have a relative afferent pupillary defect, but it will have a total afferent pupillary defect or amarotic pupil. Dr. Safa is asking about what about the normal eye in relative afferent pupillary defect? The normal one. Well, the normal is normal. So what is your question exactly? The normal will not suffer from any damage or from any effect. In case of relative afferent pupillary defect, this is a relative lesion of the one eye to the other eye. So the other eye should be completely normal. And when we are examining the other eye, there will show normal direct reflex normally. And so when we shine the light, let's say, for example, that the left eye is normal here. So when we shine the light in the left eye, this will cause normal left eye direct light reflex. When we swing the flashlight to the left eye, this will cause dilatation of the on the left eye, and this will lead to also dilatation of the right eye. When we return back to the right eye, this will cause constriction of this eye. So once you put the light on the normal eye, it will show constriction, and this means that this eye is normal. But this will be but let me tell you something, this is a matter of comparison, meaning that when you are not doing a swinging flashlight reflex and you are shining the light directly into the left eye in the first place, you can see some constriction. So you may be mistaken or mistake telling that there is no relative afferent pupillary defect. No, you are not right, because you are just stimulating the right eye. You are not putting the right eye under comparison between the withdrawal effect from the left eye and the direct constriction of the right eye. So it will constrict. This constriction will be limited according to the amount of damage, but it can show some constriction. But when you do the swinging flashlight from the left to the right and return it back to the right eye, hence or here you can find the dilatation. Another application for this comparison pattern, that let's say for example that both eyes have about 60% weakness of optic nerve. So both of them have damage, or each one of them has damage of the visual fibers or the afferent pathway, but it is the same. Can you elicit relative afferent pupillary defect? The answer is no. Because when you are comparing between both eyes, each eye will be under the equal amounts of dilatation and constriction. So it will not show the dilatation or the paradoxical response to light, because they are both damaged to the same extent. And that's why it's called relative, because it is not total, but it is relative to the another normal eye. So is this point is clear, or is do you have any question about it? Okay, for grade 2, let's say for example that this is the one eye. So we continue our example that the right eye is abnormal and the left eye is normal. So what happens when we shine the light into the left eye? Both pupils will constrict. Once we swing the flashlight from the left eye to the right eye, the left eye will dilate, start to dilate. So as we go, we withdraw the light from the left eye, so it will dilate, and the right eye will dilate as well. Starts to dilate. Once we put the flashlight into the right eye will show neither constriction or dilatation. It will remain the same size. Then it will dilate. So this means that because there is some balance between the afferent fibers, in some balance between the working fibers in the right eye and the non-working fibers also in the right eye. So there is initial balance between both of them, because it's a grade 2. It is not total damage or not a severe damage of the fibers. But since the left eye is completely normal, the effect of withdrawal from the left eye will eventually overcome this constriction effect of the right eye. So it will lead to dilatation at the end. This can be measured by another technique called the neutral density filter, or the relative afferent pupillary defect can be measured through a technique called neutral density filter. So let me explain to you with the same example. Suppose that this is the left eye, which is normal, and this is the right eye, which is the abnormal one. So if we say that the left eye is normal by amount of 100%, and this eye has lesions of about 10%, so it is working only by 90%. So in order to grade how much this is the pupil, there is a damage in the right eye, we can decrease the amount of light that will enter to the normal eye. So by putting a neutral density filter, or this filter has different grades of shading or different grades of darkening. So we can put this filter in front of the left eye, increase the amount of light entering to the left eye, so it will be about 90%. So what will happen? When we swing the flashlight between the right and the left eye, there will be no relative afferent pupillary defect. If we find that there is a relative afferent pupillary defect, then okay, this can be further or can be more. Let's say, for example, it is only 20%. So we put first a lighter neutral density filter. Then if there is a relative afferent pupillary defect, we put a more dark and a more dark neutral density filter, so that will limit the amount of light entering the eye until it will be again 20%. So there is no relative pupillary defect. So we can decrease the estimation of the amount of relative afferent pupillary defect in logarithm units provide the objective data by a quantification of relative afferent pupillary defect by determination of log unit differences need to balance the pupil reaction between both eyes. So we just need to balance the pupil reaction between both eyes so that this neutral density filter will reflect the amount of damage to the other eye. So what are the causes of relative afferent pupillary defect? There are different causes that are all involving the afferent pathway, starting from the retina, such as severe retinal disease with ischemia like central retinal artery occlusion, central retinal vein occlusion, branch retinal artery occlusion, branch retinal vein occlusion, or retinal detachment, or an optic nerve lesions like glaucoma, like compression of the optic nerve, like ischemia for the optic nerve, like optic neuritis, like tumors of the optic nerve, like compression of the optic nerve from an orbital disease such as thyroid eye disease, or then a chiasmal lesion such as chiasmal compression, or an optic tract lesion like tumor compressing the optic tract, or finally the midbrain tictal damage. So so we have, since we have 5 destinations in case of in the afferent visual pathway, any lesion involving any one of these 5 destinations will cause relative afferent pupillary defect. That's why I'm telling you that this is one of the most important localizing signs in ophthalmology, that we can know where is the lesion by know that the patient has relative afferent pupillary defect. And if you are and for you who didn't practice yet, or even those who are in practice, please don't ever dilate a patient before examining the pupil, because you have one chance to examine the pupil before dilatation. Once you dilate the patient, you will not get a pupillary response. So the optimum time to examine the pupil will be under or before putting a mydriatic eye drop. If you didn't do so, you will miss the relative afferent pupillary defect. So what happens if the patient has an efferent pupillary defect, or what is the difference between the afferent and the efferent pupillary defect? In case of the efferent pupillary defect, there will be absence of the both direct and consensual light reflex on the affected side, and there will be presence of the direct and consensual light reflex on the normal side. Let's say, for example, here is the right eye and here is the left eye, and the right eye has an efferent pupillary defect, while the left eye here is normal. In case of the efferent pupillary defect, the pupil will be dilated and fixed, while the other eye is normal at the normal size and reactive. So when we stimulate the right eye, there will be no afferent pupillary response or no direct response. When we are stimulating the right eye, there will be normal constriction of the left eye, so there will be a consensual light reflex on the left eye, but there will be absent direct. So the direct here will be absent. But when we're stimulating the left eye, which is normal, and it will cause constriction, but the indirect light reflex will be absent in the affected eye, so the indirect also will be absent. So there is absence of direct and consensual light reflex on the affected side, but when we stimulate the left eye, it will constrict. And when we stimulate or we put the flashlight on the right eye, the same eye will not constrict as there is no direct, but it will cause normal indirect reflex on the other eye. Is this clear? So in case of, again, the efferent pupillary defect, there will be absence of both direct and indirect, and the normal eye will show normal direct and indirect. Okay, so by saying that we have a lesion, why do we have always dilated fixed pupil in the affected eye. This is because there is a lesion in the efferent pathway, and the efferent pathway, as we said, starts from the Edinger-Westphal nucleus through the fibers of the optic nerve until it reaches until it supplies the constrictor pupillary muscle. So any lesion within this pathway will cause affection of the parasympathetic fibers, which pass with the third nerve. So it will cause affection of the constriction of the pupil. That's why it will cause dilatation. And this is the causes that may cause the reasons that may cause efferent pupillary defect can start even from the level of the iris. So if there is a trauma involving the iris sphincter causing rupture of the iris sphincter, so the pupil will be dilated and fixed, and this will cause anisocoria and the efferent pupillary defect. A disease called tonic pupil or Ades pupil, we will see about it later. Third nerve palsy can cause a dilatation of the pupil. Trauma, such as traumatic iritis or uveitis or ankylosing glaucoma or pseudoexfoliation syndrome and recent eye surgery, or some pharmacological agents such as using of the dilating eye drops or sympathomimetic agents such as ephedrine or cocaine. So these causes can cause, or these lesions can cause efferent pupillary defect or involvement of the efferent pathway, causing anisocoria or different pupil size between both eyes. Just hold on. Okay, so here is the efferent pathway starting from the midbrain in the Edinger-Westphal nucleus. Fibers of the pretectal nucleus, fibers from the Edinger-Westphal nucleus will pass through the oculomotor nerve until it reaches the inferior division of the oculomotor nerve. Then the nerve to the inferior rectus, so the inferior division, then nerve to inferior, so nerve to inferior oblique. Then it will relay on the ciliary ganglion. From the ciliary ganglion, with the postganglionic fibers will pass to supply the constrictor pupillary muscle. So if there is a lesion involving this pathway, this will lead to anisocoria. So what is anisocoria? As we mentioned, anisocoria meaning that there is a difference in the sizes between both pupils of about 0.3 millimeters or larger. It should be mentioned that there is normal physiological anisocoria when occur in normal population. In about 1/5 of a normal population, they have a difference in the pupil size between both eyes of less than 0.3 millimeters. And you may wonder, is it are we able to detect it? Yes, the answer is yes. So you can detect it even if it is less than 0.3 millimeter. The anisocoria, or a difference in the pupil size, may be normal, but may become a sign of ocular or neurological disease. So if you have a patient at your clinic who have anisocoria, then you should have a red alert, because there are some diseases that have a severe impact on the patient's eye or even life. Some diseases can be fatal that will manifest with anisocoria. So how can we evaluate the anisocoria? To just summarize these paragraphs, we have the eye. This is the eye, one eye, and this is the other eye, which is dilated. We can have a problem with either the smaller one or the dilated one. How can we know? This can be known by switching the light condition. So either it is in the light condition or in the dark condition. So we notice the difference in size between both eyes, and then make the patient or examine the both eyes in light condition. When the both pupils are directed to light, and in dark conditions. In light condition, if we find that one pupil is constricting and the other is not constricting, so this will be small size, and this does not dilate, or this is dilated and fixed. So the anisocoria increase in light. This means that the larger pupil is the abnormal one. On the other hand, if we have again both eyes and we have anisocoria, so there is a small pupil and there is a large pupil, and we put the patient under dark condition, and the one eye or the anisocoria become more manifest or more increased. This means that the larger, or this pupil has become more large, and that the smaller pupil is the abnormal one. So the smaller pupil did not dilate in the dark because it has a lesion, maybe involving the sympathetic pathway. And in case of light, the abnormal pupil is the larger one, as it fails to constrict under the light condition because there is a problem with the parasympathetic pathway. So if you just remember that the parasympathetic will be responsible for the efferent pathway. So if the smaller pupil is the abnormal one, this means that it does not dilate, or it fails to dilate. So the greater the anisocoria, while the anisocoria, if it is greatest in the dark illumination, then the normal pupil becomes large. While in case of, if the larger pupil becomes, or if the anisocoria increase in the dark, then this means that the smaller pupil is abnormal because it fails to dilate. While if the anisocoria more in light, this means that the abnormal pupil is the larger one because it fails to constrict. So what are the diseases that may cause, characterized by anisocoria? We have the Horner syndrome, atonic pupil, third nerve palsy, and if there is a pharmacological mydriasis by adrenergic receptors, by adrenergic agents, or anticholinergic mydriasis, so either by stimulation of the dilator pupillae muscle or by relaxation of the constrictor pupillae muscle, if there is a local iris disease or what's called Hutchinson pupil. So to differentiate between the diseases will cause anisocoria more in dark and more in light. So the Horner syndrome will cause anisocoria more in dark, and the other diseases will cause anisocoria more in light. It will be traumatic mydriasis, pharmacological mydriasis, third nerve palsy, and the Aedes pupil. From all of these, the most important is Horner syndrome because it has some physiological tests that we need to understand, but we doesn't bother to know just few information about other types of anisocoria. So starting by the anisocoria, or the Horner syndrome. The Horner syndrome means that there is a problem with the sympathetic pathway, or there is a lesion involving the sympathetic pathway. This will lead to affection of the sympathetic supply to the eye, which will supply the dilator pupillae muscle, so that the dilator will fail to dilate, leading to constriction of the pupil. So the abnormal pupil here will be the smaller one. It will be divided according to its location into the central and the preganglionic and the postganglionic. So from the central, meaning that there is a lesion between the hypothalamus and the ciliospinal center of Budge, while the preganglionic means that there is a lesion between ciliospinal center of Budge to the cervical ganglion, while the postganglionic lesion meaning that there is a lesion between the superior cervical ganglion to the cavernous sinus, which will give the ophthalmic nerve. There are various types of reasons for each one of them. I just want you to remember the dissecting aortic aneurysm, which will cause a preganglionic lesion, which will present with a sudden onset of neck pain and ptosis and meiosis, as we will see now. And postganglionic, if there is the carotid artery or the internal carotid artery dissection, can involve later on, or it can progress. It can lead to postganglionic. And cavernous sinus mass can also present with the Horner syndrome. So if there is a lesion involving the first order neuron from the hypothalamus to the ciliospinal center of Budge, this is called the central Horner. If there is a lesion involving the preganglionic fibers from the ciliospinal center of Budge to the preganglionic fiber to the superior cervical ganglion, this is called second order neuron, or the preganglionic lesion. If there is a fiber involving the after the superior cervical ganglion, then this is called the third order neuron or postganglionic lesion. So what are the features of Horner syndrome? The Horner syndrome will present with ptosis because the sympathetic system will supply the molar muscle, and the molar muscle will be responsible for retraction of the eyelid. So this will cause some ptosis or mild ptosis. Usually it's about 1 to 2 millimeters, because the molar muscle action, it will elevate only the 2 millimeters of the upper eyelid. And this ptosis is not only for the upper eyelid, but it's also for the lower eyelid. So it's called upside down ptosis because there is upper lid retractor and lower lid retractor. Both of them will be paralyzed. So neither the upper eyelid will be able to retract, and nor the lower eyelid will be able to retract. So this will cause that both eyelids will be approximating toward each other, leading to apparent enophthalmos, as if the eye is looking inward, or there is a intrusion or inward displacement of the eye. Also, the main feature here will be meiosis. So this meiosis will increase in the dim light because this eye or the meiosed eye will not dilate due to paralysis of the sympathetic system. The pupillary light reflex will be normal to light and to near. So because there is no lesion affecting the parasympathetic system, so there will be no dilated fixed pupil here. So not every anisocoria present with dilated fixed pupil, because it's only if there is affection of the efferent pathway. But here the efferent pathway is intact. It is the only problem here that the sympathetic is not working, so it will affect the dilator pupillae, not the constrictor pupillae. Facial anhydrosis will be the one important clinical sign to differentiate between the preganglionic and the postganglionic. So if the lesion is preganglionic, that will manifest by facial anhydrosis due to involvement of the fibers or the sympathetic fibers passing with the common carotid artery and external carotid artery toward the facial sweat glands. Heterochromia iridis, or the difference in the color of the pupil, in the color of the iris between both eyes, can occur in congenital Horner syndrome, because as we said in the anatomy, the development of the color of the iris occurred due to melanocytes migration, which occurs start in the embryonic life and continue later on in the few months after birth. So it will continue to develop in the 6 or 7 months after birth, and this melanocytes migration is under the effect of sympathetic system. So if the sympathetic system is not working, then there will be no melanocytes migration in the iris, so that this will lead to that the affected iris will be pale or more light in color. So in congenital Horner syndrome, this will be manifesting by all these features, but in addition to heterochromia iris. So here is a patient who have a Horner syndrome. You can see that there is an anisocoria. This is the small one, and this is the large one. And how can we know? This can be done by examining the patient on the dark. We can find that this pupil will dilate further, but this does not dilate. So the anisocoria increase in dark, meaning that this patient has, or one of the main reasons to suspect in this condition is Horner syndrome. If it is associated with ptosis, then this is a case of Horner syndrome. This is a patient who has a congenital Horner syndrome. You can see that the left eye is meiosed and there is ptosis in comparison to the right eye. But the striking feature here that the pupil color is more light as well. So this is a congenital Horner syndrome. Here, the congenital Horner syndrome, the patient has anisocoria. So the left eye is dilated while the right eye is constricted. It's associated with mild ptosis, cannot be detected very well, but you can see that there is a light color of the right iris, meaning that this patient has right congenital Horner syndrome. So here we come to an important thing, that okay, we know that this patient has Horner syndrome. So how can we know where is the lesion? Because sometimes this patient can have a mass, and this mass can have hazardous effect that can, or there can be internal artery dissection, as I told you, and we need to detect this. Let's just leave this. If this is a clinical data, let's just come to the data that will be important for the physiology. There are some pharmacological tests that that can be used in order to diagnose and localize where is the Horner lesion. So we can know whether it is central and preganglionic or it is postganglionic. So let's see what are these pharmacological tests, and I need you to concentrate with me. We have two tests to diagnose and we have two tests to localize. The first test to diagnose is called the cocaine 4%. So this is cocaine. The cocaine, this addictive drug. This is can be prepared as an eye drop and it can be used in order to diagnose Horner syndrome. This is theoretical, but in practice, due to as you know, or as you may expect, due to restriction in the use of cocaine, this is not available, but you just need to know what is the principle. So the cocaine acts by blocking the norepinephrine uptake at the postganglionic sympathetic nerve endings. So when there is what's called the neuromuscular junction, which is the junction between the nerve and the muscle, which is the constrictor pupillae muscle. This, the dilator pupillae muscle. This neuromuscular junction is under the effect of sympathetic, so it has adrenergic receptors and adrenergic neurotransmitters. So the adrenergic neurotransmitters are the norepinephrine, and the adrenergic receptors will be the alpha and the beta receptors. In case of cocaine, it will block the norepinephrine uptake at the postganglionic sympathetic nerve ending. So suppose, for example, that this patient has a normal eye. So he has norepinephrine at his neuromuscular junction. So what will happen with cocaine? The cocaine will prevent its reuptake. So it will stay in the neuromuscular junction, cause sustained action or continuous action, causing dilatation. So the norepinephrine or the sympathetic neurotransmitter will cause continuous action on the dilator pupillae muscle, causing dilatation. But since that in case of Horner syndrome, there is no norepinephrine, or to be more accurate, it is very minimal norepinephrine, there will be smaller size pupil, or there will be the difference in anisocoria will increase, because the left eye or the normal eye will dilate, but the right eye will fail to dilate because there is no or very little norepinephrine secreted. That's why the cocaine will cause anisocoria to increase. So the anisocoria, if it is accentuated or if it is magnified between both eyes, we can suspect that this patient has Horner syndrome in that eye, which is small. Again, when you put cocaine into both eyes, the normal eye will dilate while the Horner eye will not dilate. If you find this confusing, you can let's first tell you what is the pathway for the neurotransmitters. So if this nerve endings is or this nerve ending is working, let's suppose that this is the nerve of the long ciliary nerve, which supply the iris, and this is the dilator pupillae muscle. This is the dilator muscle. In order for the long ciliary nerve to stimulate the dilator muscle, there is what's called the neuromuscular junction. At this neuromuscular junction, the neurotransmitters or the norepinephrine is secreted. So it will come as a vesicle, or it is secreted through several chemical processes. Then it will be secreted by evacuation into the synaptic cleft or the synaptic junction. So the norepinephrine will stimulate the adrenergic receptors like alpha and the beta receptors, and there is a normal reuptake. So this is like a secondary feedback mechanism. So some of this neurotransmitter will pass to the plasma, some will be uptaken by the postsynaptic membrane, some will be reuptake by the nerve ending itself. So then it will undergo destruction by an enzyme called the monoamine oxidase, so that this will control the secretion of this norepinephrine. What happens here in case of cocaine? What does cocaine happen? In case of cocaine, the cocaine will prevent the uptake. Just yes. Okay. So the cocaine will prevent the uptake at the postsynaptic membrane. Okay. So this will lead to that the cocaine will be, or the norepinephrine will increase in the neurosynaptic cleft. So this will lead to that this cocaine, or the cocaine will cause increase the norepinephrine in the neurosynaptic cleft. So this norepinephrine will act on the alpha 1 and beta 1 and the beta 2 receptors, causing continuous action of the norepinephrine over the synaptic cleft and over the dilated pupillary muscle. This will occur in the normal eyes. But in case of the Horner eyes, there will be little or no norepinephrine, so the cocaine will have no effect, because it will prevent uptake of something that doesn't exist in the first place. So there will be no action or no dilatation. So this is the one way to get the information. The other way is to if you want to understand, or if you want to memorize. So if you want to memorize, you can see that the cocaine will not dilate Horner. So cocaine will not dilate Horner. This is a mnemonic, or cocaine continuous constriction. So this is the effect of cocaine on the Horner eye. It will not dilate the Horner, or it will continue the constriction. So this will be the first test to diagnose the Horner syndrome. And as I told you, it is not done, but we need to know what is its physiological principle. Here is the same process again. The second test is called the apraclonidine. So what is the apraclonidine? Apraclonidine concept, or its value, it is similar to cocaine test. It will diagnose the Horner syndrome, but the result will be the reverse to the cocaine test, meaning that it will, in case of Horner syndrome, there is an alpha 1 receptors. These alpha 1 receptors are upregulated in the denervated dilator pupillary muscle, caused denervation hypersensitivity. So if the apraclonidine is a weak alpha 1 agonist, in this concentration, the apraclonidine will not cause much effect in the normal eye. But since the Horner eye will show the phenomenon of denervation hypersensitivity, they will undergo this effect, or this drug with its weak concentration will cause its effect on the pupil, leading to dilatation. So the Horner pupil will dilate, but the normal eye pupil will be unaffected. So the result will be will be in converse to the Horner syndrome. Let's see here. You can see that again the norepinephrine is secreted into the neuromuscular junction, and it makes its action on the alpha 1 and the beta 1 and the beta 2 receptors. But what happens in case of Horner syndrome? In the Horner syndrome, there will be very minimal or even absent norepinephrine. And as a compensatory mechanism, the postsynaptic membrane cause upregulation. What is meant by the upregulation is increasing the number of the receptors. So it will increase the number of the adrenergic receptors, so that if even minimal norepinephrine will act on this postsynaptic membrane. If we put an apraclonidine, which is an alpha 1 agonist with a weak concentration, into the normal eye, it will cause no action, because this eye have normal adrenergic receptors. But if we put this alpha 1 agonist, which is weak, on the eye, which is very thirsty to any adrenergic neurotransmitter or any adrenergic agonist, then due to denervation hypersensitivity, this weak alpha 1 agonist will cause effect on this postsynaptic membrane, causing stimulation of the excess alpha receptors, leading to dilatation of the pupil. So the apraclonidine will dilate the Horner, but will not affect the normal eye. So these tests can diagnose the Horner syndrome. After diagnosis of the Horner syndrome, we can leave the patients for about 1 to 2 days until both eyes will return normal, and then we can do other tests to know what is its level. The first one is called hydroxyamphetamine. Hydroxyamphetamine 1%, this potentiate the release of norepinephrine from the postganglionic nerve endings. Again, this test will potentiate the release of norepinephrine from the postganglionic nerve endings. In case of denervation hypersensitivity, or it is also based on the principle of denervation hypersensitivity, so that the hydroxyamphetamine it will help to increase the dilatation effect caused by hydroxyamphetamine in the preganglionic corner. So what will be the result? The result is that if this patient has a preganglionic Horner syndrome, the pupil will dilate. But if the patient has postganglionic syndrome, the pupil will constrict. And why does this happen? Let's see. The hydroxyamphetamine will cause potentiation or increase the effect of norepinephrine at the or the release of the norepinephrine from the postsynaptic nerve ending. Let's see, for example, that this is the pathway. So here is the second order neuron, or here is the preganglionic, and here is the postganglionic. If the patient has damage to the postganglionic, there will be no potentiation of the norepinephrine, because all this, as we said, this is the long ciliary nerve. All these nerves will be, or all these chemical sequences will not occur or will not happen, because this patient has a lesion in the postganglionic. So there is no norepinephrine in the first place. But in case of the preganglionic, or if the patient has a preganglionic or even central lesion, this pathway or these nerves have their endogenous norepinephrine. So there will be some norepinephrine to be released in the neuromuscular junction, and what the hydroxyamphetamine does is to potentiate or to increase the release of norepinephrine. And the sense that there is some denervation hypersensitivity and upregulation of the receptors, so this potentiated secretion of norepinephrine will act on this upregulated receptors, leading to dilatation of the pupil. So the hydroxyamphetamine will dilate the preganglionic, but it will not dilate the postganglionic. So to memorize it, we can say that the hydroxyamphetamine will not dilate the postganglionic. So this is one test to differentiate between the preganglionic and postganglionic. We're using the hydroxyamphetamine. The second test is called the adrenaline, which is used also to differentiate between the preganglionic and the postganglionic. And this is based on the denervation hypersensitivity to adrenergic neurotransmitters, meaning that the adrenaline on 0.1% is a weak adrenergic agonist. If there is a preganglionic lesion, the pupil will not dilate, because the adrenaline is rapidly destroyed by the monoamine oxidase enzyme. But in the postganglionic lesion, there is a denervation hypersensitivity. That's why the ptosis will be relieved, because the adrenaline is not broken, caused by the absence of monoamine oxidase. Let's illustrate this further. Suppose that this patient has a preganglionic lesion or central lesion. Well, as we said, there will be release of some endogenous norepinephrine that will act on the postsynaptic junction. So it will, this is very, very minimal, can be potentiated by hydroxyamphetamine, as we said, but in normal occasions, it will not cause any action, and it will be reuptake. And once it is reuptake, it will be destroyed by the monoamine oxidase. Okay, so in case of the preganglionic, it will not dilate, because if we put 1% adrenaline, this 1% adrenaline will be destroyed by the monoamine oxidase. So it will cause no effect. But if the lesion is postganglionic, what will happen? As we said, all these chemicals will not occur, or all these chemical sequences will not happen. So there is no monoamine oxidase in the first place. So if we put 1% adrenaline, and it will find that there is upregulation of the receptors, so it will cause due to this denervation hypersensitivity, so it will cause action on this hypersensitive hypersensitive receptors, and even more, it will not be destroyed by the monoamine oxidase, leading to it become abundant in the neurosynaptic junction. So it will not be destroyed, and it will act on hypersensitive receptors, so it will cause dilatation of the postganglionic. So in adrenaline, it will not dilate the preganglionic and central, and it will dilate the postganglionic. So how to summarize all of this? If we have a patient who has right horner or right small pupil, then we have two tests to diagnose and two tests to detect the level. For the cocaine, it prevents the reuptake of the norepinephrine, so it will cause, if there is much norepinephrine, or this will increase the norepinephrine at the neuromuscular junction, causing dilatation of the normal eye. But since the abnormal eye or the Horner eye will have little or very or no norepinephrine, it will cause no dilatation. So the anisocoria will increase. This means that the patient has Horner, as cocaine does not dilate Horner, or it continue constriction of the Horner syndrome. The apraclonidine will act by the denervation hypersensitivity, or it will there will be a stimulation or upregulation of the alpha-1 receptors. So the apraclonidine act as an alpha-1 agonist, which will act on the alpha-1 receptors, so it will cause stimulation. And so in case of Horner syndrome, there is denervation hypersensitivity and increase the number of receptors, so the Horner will dilate. But in case of the normal eye, this will be too weak to cause dilatation of the normal eye, so the normal eye will remain the same as it is. So the apraclonidine will dilate the Horner. Then we have two tests to detect the level, one of which is hydroxyamphetamine, which will potentiate the release of norepinephrine at the neuromuscular junction. It will cause dilatation of the normal eye, but in case of the Horner syndrome, it will dilate, so it will dilate the normal eye in both conditions. In case of preganglionic Horner syndrome, there will be some endogenous norepinephrine at the neuromuscular junction in the postganglionic nerve endings. That's why it will dilate. But in case of the postganglionic, so the postganglionic Horner, there is a lesion involving the postganglionic nerves, like the long ciliary nerves, for example, so that there will be no chemical reactions within the nerve itself, so there is no norepinephrine secreted in the first place, so it will remain constricted. In case of adrenaline, the adrenaline is destroyed by the monoamine oxidase, so that this will lead to it become abundant in the neuromuscular junction, and it will increase in its concentration. And since the and the receptors also are upregulated, so they are increased in number due to denervation hypersensitivity. In case of postganglionic, there will be increase in size, but there will be the monoamine oxidase is present in case of preganglionic, so it will destroy any adrenaline in weak concentration in case of preganglionic, so that the preganglionic will not dilate. So this is the Horner. This is like the most difficult part of this lecture. Did you get it, or you have any question? Well, there are no questions. So practically speaking, these tests are all not done in clinical practice. We just do imaging. just neuroimaging in order to diagnose what is the level of Horner syndrome or what is the lesion that will cause Horner syndrome. Okay, so let's continue. There is a condition called light near dissociation or pupillary light near dissociation, as I just mentioned in the first part of lecture, in which that there is absence of the light reflex and there is intact near reflex. So in this patient, there is a light shining into both eyes, so you can see that both eyes are dilated. While the patient is looking to a near target, there is a constriction and convergence of both eyes, so the reflex is present or intact. There are different reasons for light near dissociations like Argyll Robertson pupil, advanced diabetes mellitus, some tumors for the pituitary, Parinot syndrome or dorsal membrane syndrome that I told you about, myotonic dystrophy, and adystonic pupil. So tonic pupil meaning that there is let's have we mention in detail some details, some examples for the light near dissociation, which will be first of them will be the tonic pupil. Tonic pupil meaning that there is damage to the ciliary ganglion or short ciliary nerves. So this will lead to what's called tonic pupil. Tonic pupil has some characters that we will discuss now, but just to remember that tonic pupil, there is an isochoria because there is a damage to the parasympathetic pathway, and this can be also considered an efferent pupillary defect because there is a damage to the efferent pathway. So what are the characters of the tonic pupil? The light reflex will be absent, while the near reflex is very slow, and here it is the term tonic. Tonic means that very slow. So when the patient, when we expose the patient to light, then the light reflex will be totally absent, but the near reflex will constrict very, very slowly. And also not only the pupil constriction is slow, but also accommodation is slow, or paresis. So there is a weak meiosis and weak accommodation. And since that there is the short ciliary nerves are cut or damaged, or the ciliary ganglion is damaged, so the receptors are again upregulated in the constrictor pupillary muscle, leading to denervation hypersensitivity. So if we put a weak cholinergic agent like 0.125 pilocarpine, this is a very weak concentration of the pilocarpine. This will be too weak to cause constriction of the normal pupil, but it will cause constriction of the tonic pupil because this tonic pupil is suffering from denervation hypersensitivity. And as we mentioned, since the efferent pathway is damaged, then the affected pupil will be larger. So what are the causes of tonic pupil? That can be either local, such as one of the commonest causes is inflammation by the viruses, or such as herpes, orbital or choroidal tumor, or trauma, or blunt trauma, or can be neuropathic, as in case of diabetes or alcoholism, or it could be idiopathic. And the idiopathic is called adystonic pupil, and this is important. So most books in the physiology will discuss adystonic pupil in more details. So what is adystonic pupil? As I told you, this is a denervation of the postganglionic nerves. The short posterior ciliary nerves, which carry the postganglionic fibers from the ciliary ganglion, are denervated or are damaged. So this occurs usually of unknown etiology, but some say that it could be due to viral etiology, and it has characters. It is about 2/3 of cases are unilateral, 2/3 in females, and could be associated with Holmes-Edis syndrome, in which there is an absent knee jerk. The pupil itself appears large and irregular, or there is an isochoria, which is more in light, as this is an affection of the parasympathetic system. There is a light near dissociation, meaning that the light reflex is absent or slow, while the near reflex is slow and tonic, and there is damage to accommodation, or there is accommodation paresis. So here is the pupil, so you can see that there is an isochoria. The right eye is the abnormal one, And when this patient is stimulated by light reflex, there is no constriction. But when the patient is looking to a near target, then there will be convergence and will be tonic meiosis or tonic constriction of the pupil. To diagnose this condition, we do it by the 0.125 pilocarpine test, which is a very diluted pilocarpine. When we put it into this patient has a right tonic pupil and the left eye is normal. So when we put this diluted pilocarpine in the left eye, it doesn't constrict because this is very weak to cause constriction. But since the right eye has denervation hypersensitivity, this will lead to constriction of the right eye. Another cause of the light near dissociation called the Argyll-Robertson pupil. This type of pupils is rarely seen nowadays, as it was commonly seen in patients with syphilis or tabes dorsalis. In these patients, they have bilateral small myotic pupil. They are asymmetrical and they are irregular, but they are myotic. And here is the big difference between it and the Aedes pupil. That the Aedes pupil is large, while the Argyll-Robertson pupil is small. Both of them will show the light near dissociation, meaning that the light reflex is absent, but the accommodation is present. So in order to remember it, we can remember it by this mnemonic. So Argyll-Robertson pupil, so ARP, accommodation reflex present. If you go the other way around, PRA, so pupillary reflex absent. So there is absence of the light reflex and presence of the near reflex or the accommodation. So this is a light near dissociation. Commonest causes or other causes than syphilis are diabetes or Wernicke's encephalopathy, encephalitis, midbrain tumors, and some neuropathies. So you just need to know what is present and what's absent in Argyll-Robertson pupil, and that it is myotic pupil. So here are some features. There are small pupils, irregular, with near response is brisk and on the normal. So it is not tonic like the Aedes, but it is brisk or it is rapid. So once the patient look to a near target, the both pupils will constrict normally. The light reflex is absent and sometimes it can show iris atrophy with normal visual acuity. Traumatic mydriasis, meaning that there is anisocoria, but this is due to rupture of the sphincter pupillae muscle. So this will lead to dilated pupil. Nothing you need to know more about this within the context of the basic. And also third nerve palsy can cause anisocoria, which is more in light. This is associated with the clinical manifestations of the third nerve palsy as ptosis and downward and outward deviation of the eye. So just as we said in the anatomy, we should always consider the aneurysm of the posterior communicating artery compressing on the third nerve if there is a third nerve palsy with pupil dilatation, because a third nerve palsy with pupil dilatation meaning that this is an pupillary involving, and this is and it's caused by a compressive lesion or trauma or tumors. So we'll not go through this because it was mentioned before. And the Hutchinson pupil, finally, the Hutchinson pupil is another type of pupils which is dilated. This is a dilated fixed pupil which you will not probably see in real life, but it will see in the ICU because it happens in comatose patients. And just let's see what is all this about. If the comatose patients, for example, that they have blood collection within the brain, this blood collection will cause herniation or compression of the brain. This blood compressing the brain tissue will cause herniation of the brain through the foramen magnum, and then the foramen magnum or the bone will compress the brain stem, causing compression of the center of the third nerve or compression of the superior colliculus, which has the midbrain, or the superior colliculus, which has the pretectal nucleus and the third nerve nuclei, causing compression of the Edinger-Westphal nucleus and damage of the parasympathetic supply to the eye, causing dilated fixed eye. But if the patient reaches this level, most probably that this patient will not live. So there is an ipsilateral expanding intracranial tentorial mass, such as subdural hematoma, that will cause downward displacement of the hippocampus and ankle herniation across the tentorial edge with entrapment of the third nerve. Then the pupillomotor, which will be traveling in the peripheral portion of the third nerve, are subject to damage, to early damage from the compression. So it can even be damaged even before the center itself will be damaged. And further herniation will lead to that compression of the brainstem followed by respiratory arrest due to damage of the respiratory center. So if you find this patient has some pupillary dilatation, if you are examining the patient in the ICU, please be aware of the Hutchinson pupil. So any questions so far? Yes, we'll take a break. I know that the pupil is not that easy. So we will take a break now, and we will be back about after 15 minutes in order to continue the visual acuity. I promise you the visual acuity will be much more lighter and much more easier.